Now, let's move on. Now, regarding the normal physiology of menstrual cycle, it is now well established that a normal menstrual cycle depends on cyclical ovarian steroid secretion, which in turn are controlled by pituitary gland and then hypothalamus. So we need three things here. One, normally working ovary. Okay, ovaries are gonad of female, and these ovaries are responsible for secretion of estrogen and progesterone. Then pituitary gland, which should be normally functioning again, and then hypothalamus. This is known as hypothalamo pituitary ovarian axis, HPO axis, you can say, which should be functioning. And to some extent, they are influenced by thyroid and adrenal gland. Now, what is the role of thyroid and adrenal gland? Here, we're going to talk about this. Remember, in case of hypothyroidism, there is excessive TSH or TRH. That TRH specifically, okay, leads to overproduction of prolactin, hormone, and that prolactin hormone is acting as antigonadal hormone. You can also call it anti-estrogen hormone. So there's a bit of a correlation there. Adrenal gland, on the other hand, is producing some sex steroid. We all know those sex steroid, especially androgen, has anti-estrogenic effect again. Androgen and estrogen, they are antagonizing each other. So there is a bit of role. Let's move on. See there. Hypothalamus regulates the function of anterior pituitary gland through portal vessels, by releasing both stimulatory and inhibitory hormone that in turn influence the function of the target tissue through the systemic circulation. Now, what do you mean by that? These portal blood vessels, I'm sure everybody know the meaning of portal vessels. Just like a portal vein in the abdomen, it has got two sets of the capillary on either end. One end, okay, those capillary will fuse together to form portal vein, and then when it reaches its target area, then it will again branch into the smaller capillary. So portal circulation means always it has two sets of the capillary. Remember that. The same type of arrangement is there in anterior pituitary gland and in hypothalamus also. That is the meaning. So the function of hypothalamus is it will control the pituitary action by releasing stimulatory and inhibitory hormone. Let's move on. Very normal thing we are talking here. Now, gonadotropin releasing hormone, see that GnRH, gonadotropin releasing hormone, is secreted by the median eminence. This is one part of hypothalamus. This is a part of hypothalamus, okay, which modulate the neural control of FSH and LH by the anterior pituitary gland. So FSH and LH are called gonadotropin. They are known as gonadotropin. So there is a hormone which is released by hypothalamus, which will control this FSH and LH, and that is known as GnRH, gonadotropin releasing hormone. Very easy name. Gonadotropins are FSH and LH. If something is controlling the release of them, we call them gonadotropin releasing hormone, which is definitely secreted by hypothalamus. This arcuate nucleus of hypothalamus also secrete prolactin inhibiting factor, which is actually nothing but dopamine. This prolactin inhibitory factor is dopamine, and this dopamine always inhibit the release of prolactin. Okay, this is such an important, connection between dopamine and prolactin. You should never forget. Having said that, if I give certain drugs which block the release of dopamine, what will happen to the prolactin now? Yes, what will happen to prolactin if I give dopamine blocking drugs?
So there will be higher level of the prolactin, sir, now.
Exactly, absolutely correct. So there will be hyperprolactinemia, high level of prolactin in the blood, because you have blocked, you have inhibited dopamine. Okay, and dopamine is the inhibitory hormone for prolactin. Means prolactin will be higher in level, and that exactly happens if you give dopamine blocking drugs. Can you name some of the dopamine blocking drugs? Anybody? Yes. Which are dopamine blocking drugs?
Sir, may I, sir, sir, we can give like sir the like sir thorazine, like sir reglan, like sir chlorpromazine, sir, and clopramide, and sir promethazine, and sir paliperidone, sir.
Pantixone.
Very good, very good. The drugs you are telling me are correct. You can remember like this. Some anti-emetic agent, some of them, not all, okay? Some of the anti-emetic agent like metoclopramide is right, metoclopramide or domperidone, especially metoclopramide, and many of them antipsychotic drug like chlorpromazine, haloperidol, okay, flufenazine and all those, they are a dopamine antagonist. So one of the side effects of them is hyperprolactinemia. Now, during late pregnancy and lactation, a low or absent inhibitory factor leads to high secretion of prolactin that initiate and maintains the lactation. So this is a physiological thing now. Okay? Nothing is, stimulating or inhibiting here. This is just a physiological need during that time, because during lactation, the lady should produce more milk. So this is what is happening. Let's move on. Now see that, okay, this slide is making those things very easy for you. Here is hypothalamus. Hypothalamus is releasing gonadotropin releasing hormone. It acts on the anterior pituitary, and from anterior pituitary we have FSH and LH. These are called gonadotropin, follicle stimulating hormone and luteinizing hormone. The follicle stimulating hormone acts on ovarian follicle, okay, especially the follicular cells of the ovarian follicle, and it will help in the growth of that ovarian follicle. LH mainly acts on the follicle when it is mature. It leads to ovulation by rupturing the Graafian follicle, and after that it helps in the formation of corpus luteum. This is LH. Now a lot of function is there which is going on actually. So we'll talk about that one after other. Okay, just the main thing now. So ovarian follicles release estrogen and corpus luteum release progesterone. Now this is the main action of estrogen on the endometrium. It leads to proliferation. This is known as proliferative phase of the menstrual cycle, whereas the progesterone changes that proliferative endometrium into secretory type of endometrium. Now, this secretory endometrium is necessary for the future, okay, pregnancy, if it occurs. If it doesn't occur, then everything will come out as a menstruation. Okay, we'll talk about that in today's class, or you already know it. Everything comes out as a menstruation. Whereas if the lady becomes pregnant, then that fertilized ovum has to implant on the secretory type of endometrium for the growth. This ovarian follicle also releases inhibin. This is another hormone which is especially responsible for negative feedback on the anterior pituitary gland. At the same time, this estrogen and progesterone both also give negative feedback to the anterior pituitary. So this is how the control of the hormone occurs. A little bit more about this GnRH, because a lot of questions can be asked in your exam. Gonadotropin releasing hormone are released in a pulsatile manner into the portal vessels. So remember, this portal vessel is not the portal vein of the abdomen, okay? It is the portal circulation which is present in the area between hypothalamus and anterior pituitary, or pituitary stalk, you can say. And it reaches the anterior pituitary gland. The pulsatility and amplitude of its release varies with the various phases of the menstrual cycle. Now see here, in the pre-ovulatory phase, are also known as follicular phase. Before the ovulation is follicular phase. It pulses once in every 60 minutes. but it slows down to once in 3 hours in the luteal phase. Now, let me clarify this. This release of GnRH is in a pulsatile manner. It is not a continuous manner, pulsatile manner. If we make it a continuous type of release, okay, if we make this pulsatile release into a continuous type of release, then it will lead to suppression of release of gonadotropin. This is very interesting, mechanism of action here. And this is done through the process of down regulation or desensitization of pituitary hormone. Now, let me clarify this once again. This GnRH, okay, GnRH, if we convert this pulsatile release into a continuous release by giving some GnRH agonist drug, which are available, they are commercially available, then rather than stimulation of the release of gonadotropin, they lead to suppression of the gonadotropin release. There will be no FSH, there will be no LH, okay, and it leads to decreased estrogen production, which we want in the clinical practice in the treatment of certain condition. One of the conditions we have already talked before, which is that condition where GnRH is used as the drug. Yes, the treatment purpose. Yes, which one? It is fibroid uterus or leiomyoma. Remember, leiomyoma is a estrogen sensitive benign tumor of the uterus. So we have to block that estrogen release by ovary. And if we block FSH and LH, that estrogen will not be produced. That is the whole idea behind it. Let's move on. Now, epinephrine and estrogen stimulate, whereas dopamine, serotonin, and opioid inhibit the release of GnRH by the hypothalamus. So let me clarify this again. See here. So epinephrine and estrogen stimulate, whereas dopamine, serotonin, and opioid analgesics inhibit the release of GnRH by the hypothalamus. Gonadotropins also inhibit GnRH secretion. Now, this gonadotropin will definitely give negative feedback for the GnRH secretion, like increase FSH and increase LH will block the release of GnRH. Epinephrine, okay, is a stress hormone, okay, whereas estrogen, this is a bit of controversial statement for the student. Just now I have told estrogen will give negative feedback, okay, to the release of FSH, LH as well as GnRH. But there is one exception here. Near the mid-cycle, when the time for ovulation comes, estrogen will give positive feedback to all these things. So apart from that, high level of estrogen will definitely lead to negative feedback. Now, what are the use of GnRH in clinical practice? See there. Okay, this is a very important question for you. The synthetic analogs of GnRH are used in the following situation. They are pre-operative shrinkage of uterine fibroid. That's what I discussed just now. Leiomyoma or fibroid. The medical management is done by GnRH analog. We have discussed that before. And after that, surgery should be done. Shrinkage of endometriosis. Now, endometriosis is the presence of endometrial tissue outside the uterine cavity. Now, it will also depend on the estrogen, okay? That estrogen and progesterone, all those things, it depends regarding the bleed. So if we continuously block the release of estrogen, then there is a shrinkage of endometriosis tissue. Shrinkage of endometrium prior to endometrial ablation, okay? Ablation means removal. Hirsutism, okay? Hirsutism, because remember, this if we block this, stimulation of the ovary, then ovary is also responsible for the release of androgen. So hirsutism is done by androgen, okay? So if you inhibit the release of the androgen from the ovary, hirsutism, okay, may not occur. So that is the mechanism here. Precocious puberty, which is also done by estrogen, in vitro fertilization, and even prostatic cancer. So all these things are there. Now, prolonged administration over 6 months can cause estrogen deficiency and osteoporosis. So they should not be used for a long-term basis. They should be used on a short-term basis only. But the important point here is after we stop using them, then that osteoporosis will come back to the normal, especially if the lady is, maintaining other things. This GnRH is degraded in the GI tract, so it should be given only through the parenteral route, like intravenously, subcutaneously, or even intranasally. These type of preparations are also available. What are the some of the side effects of GnRH? Insomnia. What is insomnia?
Sleeping disorder.
Sleeping disorder.
Very good. Okay, person is unable to sleep. Insomnia. Okay, so this may be one of the side effect. Nausea, which is very easily managed. Osteoporosis caused by estrogen deficiency, but reverts to normal after the stoppage of the drug. Decrease in breast size, which is again reversible because of the again blockage of the estrogen. Decrease libido, okay, decrease libido, again blockage of estrogen as well as androgen, and decrease in high density lipoprotein and increase in cholesterol by 10% of the each. Means both of them are increased by 10% than if we compare with the same lady who is not using this drug. Now see this. What is the function of HDL in our body? Yes, function of HDL. Anyone?
Sir, it prevents the atherosclerosis and deposition of the cholesterol and
Hey, sir.
Yes, you're right. Yes, yes, please, please, you can
Sir,
explain.
basically, like sir, basically, sir, like the HDL, like sir, the HDL, sir, like it is, like sir, it absorbs the cholesterol and carries it back to the liver. So, sir, as Irfan said, like sir, when there is less cholesterol, there is less chance of atherosclerosis, and sir, vice versa, of course.
Less chances of heart diseases.
Exactly. All of you are right. You already have the concept. Very good. So let me quickly clarify this. These are called lipoproteins. These lipoproteins are lipid carrier proteins in our body. Okay, lipid carrier protein. Cholesterol is one of the very important lipid which is present in our body. And this cholesterol we need cholesterol actually. But if cholesterol is in excessive amount, then it may be damaging for our body as well. So it should be maintained. Okay, so there are two types of carrier here. One is called LDL, another is HDL. There are so many others also. Let's not go into the detail here. LDL, okay, is carrying cholesterol from the liver and depositing the cholesterol into the tissues. So it carries or transport cholesterol from liver into the tissues. So this is a bad type of cholesterol carrying protein, or you can simply say it is a bad cholesterol which is attached to the LDL. Whereas HDL has opposite of the action. It will transport cholesterol which is deposited in our tissues back to the liver so that cholesterol can be handled there. Okay, so we want low level of LDL but high level of HDL in our blood. Never forget this. We want more HDL but low LDL to become healthy. If somebody is having very high LDL and low HDL, they have a high chance of development of atherosclerosis. Absolutely correct. And then so many problems of atherosclerosis like myocardial infarction, okay, stroke, peripheral vascular disease, mesenteric arterial occlusion, all those things can happen. Now, let's come to the point here. Why? What is the connection with the female here? See this. If we persistently decrease the level of estrogen, okay, there is decrease in high density lipoprotein and increase in cholesterol. That's why after the period of menopause, okay, estrogen is absent. It's very decreased, not absent. There is a bit of estrogen formed because of aromatization in the lipid or fatty tissue. Let's not go into there now, but the level of estrogen is massively decreased than in the reproductive age group. That's why there is equal chance of development of atherosclerosis even in female like in male after menopause. This is the reason. Okay, so if we block the estrogen release by using GnRH, then the risk is higher even during the menstrual period. Now, these are some of the example for you. If they ask, in some of the MCQ exam, probably they may ask. So these are the drugs and their administration: naferelin, okay, buserelin, goserelin, leuperide, and triptorelin. These are the name. So you just remember this relin at the end: naferelin, buserelin, goserelin, triptorelin, and leuperide. These are the drugs. You don't need to know about how these drugs are given. Nobody is going to ask this now. Just the names are important at this stage. Okay. Now see there, some of them are given intranasally, some are given subcutaneously, some are even given intramuscularly, like that. Okay. So basically, they are not given orally. Now, after learning something about those GnRHs, let's talk about gonadotropins. Now, from where these gonadotropins are released? They are released from anterior pituitary gland. Okay, these are released by beta cells, or also known as basophilic cells, which are a type of cell present in anterior pituitary. So they release gonadotropin hormone. These gonadotropin, they control the ovarian function and the menstrual cycle. They are FSH and LH most importantly. If you remember these are just these two, you will get the maximum marks. But the other are also mentioned here, like TSH and corticosteroid hormone. They also play a bit of role. That's why they are mentioned here. Each of these hormone has alpha and beta fraction, just like beta HCG. You have studied that before. Beta HCG means beta fraction of HCG. So similarly, these hormone also have the same type of fraction, alpha and beta. Alpha fraction is identical in all, whereas beta fraction is specific in each of the hormone. If I compare FSH, the beta fraction of FSH, the beta fraction of LH, and beta fraction of HCG, they are different. They are specific to each of them, but alpha fraction in all of them are similar. Now, all of you please focus on this, graph. See here. These are the gonadotropins, FSH and LH. Exactly in the mid cycle, there is ovulation. See there, ovulation. Okay, and you can clearly see near at the time of ovulation. Look at the LH. The LH level is very high. This is known as LH surge, and this LH surge leads to ovulation. FSH is also slightly high during that time, but not as high as LH. Okay. Now, this is estradiol. Estradiol is a form of estrogen. Okay. And here is the progesterone. Now, this is very clear-cut thing for you. After ovulation, only the progesterone. Okay, progesterone will be higher there. It is the baseline. Otherwise, it is in the baseline. Whereas estrogen is gradually increasing during the pre-ovulatory phase. And this estrogen is released by follicular cell. Okay, and then it will even be released during the secretory phase. Now, these are the ovarian functions. Oocyte, they gradually become increased and reach the Graafian follicle. Actually, only one of these follicle is selected, and they will increase in size to form Graafian follicle, and that also switch between each of the ovary in every menstrual cycle. Means one menstrual cycle, one ovary is selected for the development of graphene follicle, whereas in next cycle, the another ovary is selected. Now see there, rupture, there is ovulation, formation of corpus luteum, and then corpus albicans. This is a degeneration of the corpus luteum. And this is the uterine endometrium, what is happening there. And this is the proliferative phase. This is done by the action of estrogen. This is the secretory phase. This is done by the action of progesterone. And exactly here, okay, ovulation occur. And the first 4 days are called menstrual phase, where the menstruation occur. Okay, and they have taken 28-day cycle here. So 14 day prior to menstruation is ovulation day. So exactly this day ovulation occur. We can even guess when ovulation occurs in that lady, but remember the cycles should be regular. If cycles are irregular, then we cannot guess that. Now let's talk a bit about gonadotropins, FSH and LH. What are the important action? This is important class. Now, FSH controls the ripening of the primordial follicle, and in conjunction with LH, it activates the secretion of estrogen. Definitely. The most important function is development of follicle. Okay, this is known as ripening of the follicle. Its activity builds up as the bleeding starts to cease and reaches a peak around the 7th day of the cycle, then declines to disappear around the 18th day. After that, there is no role of FSH. The main function of FSH is before the ovulation. It should make that follicle ready. Okay, that is the main job. That's why the peak occurs around the 7th day. Half-life of FSH is around 4 hours. This is purely pharmacological knowledge. Low FSH causes defective folliculogenesis and short or defective corpus luteal phase. Definitely. Okay, everything is depending on this, isn't it? If follicle is not mature enough, then corpus luteal development is also a problem, because ovulation will be a problem. Without ovulation, development of corpus luteum may not occur. Estrogen suppresses FSH secretion through negative feedback mechanism. All of us know this point. See there, estrogen is released by those granulosa cells. It will give negative feedback to the pituitary for the release of FSH. It develops LH receptor in the granulosa cell, where LH can act later on. Okay, so not only the release of estrogen, but the development of LH receptors is also done by FSH. Now, let's know a bit about LH now. In conjunction with FSH, it activates the secretion of estrogen, brings about the maturation of the ovum, and then causes ovulation. Now, 2 important points you need to know here. 1, LH is responsible for ovulation. Okay. Now, the maturation of this graphene follicle is done by FSH. There is no doubt about it. But at the time of ovulation, the rupture of that graphene follicle is done by LH, and it activates the secretion of estrogen. LH stimulates the completion of the reduction division of the oocyte. Following ovulation, it produces luteinization of the granulosa cell and the theca cell and initiates the progesterone secretion. This is the synthesis or formation of corpus luteum. So corpus luteum formed is done by LH. There is one important point for you, but I have repeated this so many times. This is known as LH surge. This LH surge precedes the ovulation by 24 to 36 hours. Okay, 2 to 3 days. 2 to 3 days prior to that, and it leads ovulation. So this is an important question for you in the MCQ exam. Okay, remember LH surge or LH hormone, which is most importantly responsible for ovulation. This LH, okay, stimulate the secretion of testosterone and androstenedione in the ovarian stroma, which are known as thecal cell or theca cell. Now, these thecal cell are responsible for the synthesis of androgen. You already know that. Okay, this is not the first time we are learning this. Now, what happens? These androgen are aromatized. They are aromatized by the follicular cell into the estrogen. This is a form of estrogen which is known as estradiol. Okay, this is the important mechanism. So we need both these hormone actually for the proper synthesis and release of estrogen, because without the development of follicular cell, aromatization reaction cannot happen, and without LH the synthesis and secretion of androgen doesn't occur. So see this? So we need both a type of gonadotropin, FSH and LH, for the release of estrogen. Both. Okay, only one is not enough here. We need both. The half-life of LH is 30 minutes. Now, we already know that estrogen is released. So let's talk about this estrogen. What are the functions? The main source of natural estrogen in the female body are theca and granulosa cell of the Graafian follicle as well as corpus luteum, while the adrenal cortex is the secondary source of supply. It is secondary. Yes, it is also secreting, but that is very minimal amount, very minimal. Now, there are different forms of estrogen. In the reproductive age group, the natural form of estrogen is estradiol. Okay, the active form of estrogen, estradiol. It is bound to albumin in 30% and sex hormone binding globulin in 69%, and only 1% is biologically active. Now, see that in the last few classes, we talked about sex hormone binding globulin also. It is formed by liver or produced by the liver. Okay, so the main function of this is carrying, okay, or transport of this female hormone estradiol. Even in male it is present. In male it is carrying the testosterone. It acts by binding to cytoplasmic receptor in the cell. These are steroid hormone, remember that. Okay, steroid hormone, they mainly act on cytoplasm. They have a receptor in the cytoplasm. They act there, and the receptor hormone complex will move into the nucleus, and then it will modify the functions of the genes there, and doing that, it will show its action. It is inactivated by the liver and excreted as the conjugate of estrone, estradiol, and estriol in the urine and bile. 85% is excreted in the urine and 10% in the feces. Now, let me correlate clinically some of the important points here. Okay, please listen properly. In case of chronic liver disease like cirrhosis of the liver, okay, this estrogen cannot be metabolized, so it will remain for a longer duration, okay, inside the body. So if this is a male patient, remember in male also there is a slight amount of estrogen present, and if this estrogen cannot be metabolized, what are the clinical features produced by that estrogen now in male body in case of cirrhosis? Anyone?
Gynecomastia.
Yes, sir.
Female characteristic.
Enlargement of the
Exactly, very good. Gynecomastia is one of the most important point there. Gynecomastia, and I'm not sure whether you have studied cirrhosis of the liver in internal medicine or not, but you will study this later on. This is a huge topic there, very important one. One of the important clinical feature is gynecomastia. Okay, another one is loss of axillary and pubic hair. Loss of axillary and pubic hair. This is also done by excessive estrogen presence in the male body, because to maintain those, we need androgen, not estrogen. And androgen and estrogen are always antagonizing each other. So these are some of the important points there. Even the palmar erythema is assumed to be caused by excessive estrogen. in case of cirrhosis of the liver. The plasma estradiol level rises approximately 6 to 7 days before the ovulation to the peak level about 2 days before ovulation and approximately 24 hours before the LS peak. Thereafter, the estradiol concentration falls. So basically, the level of estrogen or estradiol is high in pre-ovulatory phase before the ovulation. And we all know, because that time there is proliferation of the endometrium occurs, and that is done by estrogen, and that is the time where estrogen is maximum. But even after the formation of corpus luteum, there is a continuous release of estrogen. Okay, so don't say like estrogen will not be there. Estrogen will be there, but the level of the estrogen falls a little bit after that. That is the point. Now, to summarize all these things which you have learned till now, see this. This is called Graafian follicle. These are the theca cell, and these are the granulosa cell. Theca cells are considered as the connective tissue cell. Granulosa cell are the epithelial cell. So theca cells form androgen first. This androgen will be aromatized into estrogen by the granulosa cell, and this estrogen. Now we're talking about the estrogen, and we'll talk about what are the functions of estrogen now. Now there are three forms of estrogen: estradiol, estrone, and estriol. Okay, these are the forms of estrogen: estradiol, estrone, and estriol. Now this estradiol is the most potent one among all type of estrogen. This is 10 times as potent as the estrone and is present during the reproductive period. After menarche till menopause, inside the body, estradiol is the most predominant type of estrogen. Estrone, on the other hand, is derived from peripheral aromatization of androstenedione. This is a sex steroid, or you can say this is a type of androgen, which is predominant in menopausal women. Now see that in menopause, isn't it? The ovaries, they do not function well. So what is the source of estrogen then? The estrogen is obtained from aromatization of androstenedione, which is secreted by adrenal gland, and this aromatization occur in the peripheral fat, and that is a main source of estrogen in postmenopausal women. This is much weaker type of estrogen in comparison to estradiol. In the pregnancy, placenta is the main source of estriol. This is another type of estrogen. Let's move on. Now let's talk about what are the actions of estrogen here. The most important action is feminization and development of secondary sexual characteristics. Feminization means the female body looks like female body because of the effect of estrogen. This is a very important action. That's why estrogen is also known as female hormone. Female hormone. And development of secondary sexual characteristics also done by estrogen. That means at the time of puberty, the girl starts to have an enlargement of the breast. She will have other features that it after looking them, then we know yes, she has entered the pubertal age. That is called secondary sexual characteristics. This is all done by estrogen. There are specific action of estrogen on the genital tract, like in the vulva and vagina. This estrogen is doing the proper development, the epithelial stimulation, cornification of the superficial layers of the vagina. This cornification is the term from stratum corneum. Stratum corneum is the most superficial layer of the epidermis. And then deposition and metabolism of intracellular glycogen in the vaginal epithelium. So all of these are some of the important action. This glycogen is present abundantly in the vaginal epithelium. And one small clinical correlation now for you, there are some local commensals or some of the bacteria, we call them normal commensal also, which are present in the vagina. And the important example are called lactobacilli. Lactobacilli. Okay, these lactobacilli will cause metabolism of this glycogen there and maintain a bit of acidic environment there. So this is like a defense mechanism in case of vaginal epithelium. Let's move on. Now, what is the function of estrogen on the uterus? Now, see this. In the uterus, estrogen causes myohyperplasia of the myometrium as well as cervix. Myohyperplasia. This is a smooth muscle which is present in the uterus. So hyperplasia. What is hyperplasia, by the way? What do you mean by that? Yes.
Increase the number of
Increase
cells.
in number of cell.
Excellent. Excellent. Increase in number of cells is called hyperplasia. Increase in size of the cell is called hypertrophy. Very basic term. So every student know that. So increase in the number of muscle fiber is also done by estrogen. It increases uterine vascularity, blood vessels, regenerate the endometrium after menstruation, which is known as proliferative phase of the endometrium. Okay, it occurs in the pre-ovulatory phase. Estrogen causes proliferation of the epithelial lining, glandular cell, stroma, and even leads to mitosis, means division of the cell. So this is the function of estrogen there. Means the most important action of estrogen lies in the pre-ovulatory phase or proliferative phase. Estrogen has a stimulant effect on the glands of the endocervix and their mucus secretion. So these are action of estrogen on the uterus. Now, what is the action of estrogen on the breast? See there. Now, it will lead to hypertrophy of the ductal and parenchymal tissue of the breast. It also leads to increased vascularity of the breast. It leads to areolar pigmentation, but no galactogenic effect. This is important one. So overall, enlargement of the breast is done by estrogen, but the secretion and synthesis of milk is not done by estrogen. That is the meaning of no galactogenic effect. We need prolactin for this effect. Okay, prolactin hormone is necessary for this. Large dose of the estrogen suppress lactation. Okay, large dose of estrogen suppress lactation. Now, action on other endocrine gland. What is the action of estrogen on other endocrine gland? Now, we all know estrogen suppresses FSH, okay, LH, and thyrotropic hormone from the anterior pituitary. So this is called a negative feedback of estrogen there. FSH and LH, we all know that, but even thyrotropic hormone is, decreased. It can be used to inhibit ovulation as also production of milk in the puerperal patient. Now, ovulation inhibition is done by high dose of estrogen because of negative feedback again. If it is blocking the release of FSH and LH from the anterior pituitary, ovulation would be inhibited. In some of the situation, if the production of milk in the puerperal patient needs to be decreased, we certainly go for the use of estrogen. It is a stimulant to the LH and thereby corpus luteum formation. Now, this is known as LH surge. Now, overall effect of estrogen and LH is negative feedback or inhibition, but there is an exception. Near to the time of ovulation, it gives positive feedback to the LH release, and that's why it is mentioned here. Now, some other important actions of the estrogen, okay, which have a important clinical correlation as well. What is the effect on skeletal system? Estrogen increases calcification of the bone and closure of epiphysis in the adolescent and is antagonistic to somatotropin. Now, what is somatotropin? Yes,
Sir, somatotropins are
It's a
the
growth
which
hormone
release growth
released by the
hormone.
pituitary gland.
It increases the production of growth hormone.
it is actually growth hormone itself. Okay, it is growth hormone. Very good. So it leads to increase uh, synthesis of the substance inside the cell, or it leads to increase in size of the cell, increase in size of the tissue. That is the action of somatotropin. Now see this estrogen is antagonistic to somatotropin, especially in the skeletal system. So having said that, if a lady is having excessive amount of estrogen near the pubertal age, okay, or during that time, then the overall height of that girl may be decreased because of the antagonizing effect of estrogen on somatotropin. This is important function. And another one, it increases calcification of the bone. That is a good thing in the bone actually, but because of the estrogen deficiency, there may be osteoporosis. Opposite thing will happen. So osteoporosis is quite common when estrogen is deficient, which is written here. In postmenopausal woman, osteoporosis is very, very common to occur. That's why, in postmenopausal woman, we often supply them with vitamin D and calcium because they don't have naturally formed estrogen in their body. Yes, a little bit of estrogen is present, which is known as estrone. Okay, it is there, but it is much weaker in comparison to estradiol. Now, regarding water and sodium metabolism, estrogen tends to cause water and sodium retention. This is a steroid hormone, remember that. So any type of steroid hormone is having this type of effect, water and sodium retention. Regarding the blood cholesterol, okay, this action we have just discussed, so students are quite fresh. Blood cholesterol levels are to a small extent controlled by estrogen in the female body. HDL increases under estrogen influence, and therefore it is cardioprotective. That's why we hardly hear, during reproductive age group, a lady is having myocardial infarction or heart attack. This is very, very uncommon. And if somebody asks you why this is uncommon, you can take the name of estrogen here because of the estrogen influence. It is increasing the HDL, synthesis, and HDL is cardioprotective in nature. Now, at the same time, there is one, negative type effect also. By raising fibrinogen level, it can cause thromboembolism and is a major side effect of estrogen. Now, fibrinogen, okay, is a type of clotting factor. It is clotting factor number one actually, fibrinogen. We all know that. So excessive level of fibrinogen will lead to thrombus formation, and that thrombus, okay, can lead to blockage of different types of circulation. Okay, so this is considered one of the major side effects of oral contraceptive pill. It increases sex hormone binding globulin synthesis by the liver as well. Now, after knowing some of the effects of estrogen, let's go and talk about progesterone, another important hormone which is released by ovary. And the source of ovarian hormone here is the corpus luteum. Small amount is also derived from adrenal gland, but this is very less significant. The plasma level of progesterone rises after ovulation and reaches a peak level at mid-luteal phase. Mid-luteal phase, okay, somewhere between the ovulation and the menstruation. Exactly middle part of that is mid-luteal phase. With the degeneration of the corpus luteum, the level of progesterone falls, and this brings about menstruation. Yes. So just think about why menstruation occur, because of abrupt decrease in progesterone level. Okay, because that corpus luteum cannot survive all the time. It will degenerate into corpus albicans. So there will be no progesterone. Without progesterone, the maintenance of secretory endometrium will not occur. So this is the main reason for menstrual flow. In an anovulatory cycle where there is no ovulation, progesterone is absent or is in negligible amount, because some amount of progesterone is also secreted from extra ovarian sources, but that is not enough to maintain the function. So there is certain cycle known as an ovulatory cycle. Many ladies suffer from that, they don't have ovulation. So they have excessive estrogen in the body, but they don't have any progesterone. And this is called unopposed type of estrogen stimulation. And this is not good for the female body. If pregnancy occurs, the corpus luteum persists, even enlarges and continue to secrete progesterone. So which hormone is maintaining this corpus luteum during pregnancy? Which hormone is that?
Beta
Absolutely, beta HCG.
for
Okay,
3 months, but after this placenta produces the progesterone.
exactly. First beta HCG, very good, beta HCG, and later on, when placenta becomes mature, placenta is directly producing progesterone. Excellent. You see that? This is the way I keep on asking the question so that students remember this. If we do not do this, we tend to forget. Now, what are the actions of progesterone here? Just like estrogen, let's talk about that. In endometrium, progesterone causes secretory hypertrophy and formation of decidua. This is a very, very important function. Probably the most important function is this. Glycogen and mucus collection occurs in the tortuous gland of the decidua because of progesterone. Okay, decidua is a secretory type of endometrium. Now, in pregnancy, progesterone initially, secreted by corpus luteum and later on from the placenta directly. And we need progesterone for the continuation of pregnancy. Remember, progesterone is a relaxing type of hormone, relaxing. So it is relaxing the uterine musculature so that the undue contractility of the uterus doesn't occur. So if a uterus starts to contract right from the beginning, remember, there would be termination of pregnancy. There may be probably abortion, or after 20 weeks of gestation, if that happens, then preterm labor. So progesterone is very, very important hormone for the continuation of maintenance of pregnancy. In the uterus, progesterone causes myohyperplasia of the uterus, and they increase the strength but diminish the frequency of uterine contraction. This frequency is what it matters here. Now, what is the action of progesterone on the breast? Progesterone, along with estrogen, causes hypertrophy of the breast. They also increase acinar epithelial growth. So they also cause overall breast enlargement. In the pituitary gland, the exact action of progesterone is not well known, but along with estrogen, we consider progesterone as also the inhibitory hormone. Okay, it is an inhibitory one, means it will also give negative feedback along with estrogen. Regarding the fluid retention action, progesterone causes water and sodium retention, just like estrogen, and is a contributory factor in premenstrual tension and weight gain. Premenstrual tension and weight gain. Now, this means just before the menstruation occurs in a lady, she may have mood swing. She may have mood swing. She may feel very irritable or sometimes even depressed. Okay, so all these are called premenstrual tension, and this is done by progesterone because progesterone is present during that time. Now, what is the action of progesterone in the smooth muscle in other part of the body? Progesterone relaxes the smooth muscle. Uterine muscles are already relaxed by progesterone. We talked about that, but they also relax GI tract and even the ureter. Even the ureter. So as a result of that, constipation is very common during pregnancy because the relaxation of the GI tract, especially colon. And what happens if ureter are dilated? Any thing happen? Anyone? Until and unless they are blocked, nothing will happen. Okay, until and unless they are blocked, because urinary flow is still maintained there. But let me clarify some important point right here. There is also constipation going on. That constipation is caused by progesterone, caused by the direct compressive effect of the uterus, okay, and things like that. Now, because of this constipation, the ureter may be compressed, especially on the left side. And as a result of progesterone, also ureters are a bit dilated. So the lady may develop hydronephrosis during because of this. But this hydronephrosis is never that serious, okay? Because the complete obstruction never occurs there. And after delivery, everything will come back to the normal. Progesterone raises the body temperature by 0.5 degrees centigrade. So this is known as increase in basal body temperature. And this basal body temperature charting is based on its thermogenic effect during the menstrual cycle. Let me clarify this again. Some of the lady, they know when ovulation has occurred by measuring the body temperature, around the time of ovulation or around the time of mid-cycle. They know exactly when ovulation has occurred and which day ovulation has occurred, because after progesterone, the body temperature rises. This is known as thermogenic effect. Anabolic effect of the progesterone are it causes weight gain. This weight gain is anabolic effect, isn't it? But many of these are most important cause of the weight gain is fluid retention in this case. And progesterone diminish libido. Okay, uh, this is not a very important action of progesterone. Libido is decrease in sexual desire. Okay, libido is a sexual desire, of course, but diminution of libido occurs here. Okay, so this is caused by excessive level of progesterone. Now, after knowing all these basic things, okay, in today's class we are mainly focused on physiological aspect. But let's talk about the menstrual cycle after knowing the action of estrogen and progesterone. See here. The periodic structural change of endometrium of uterus during reproductive life is known as menstrual cycle. So what is happening? After menstruation occur, the endometrium will develop proliferative phase. In the middle of the cycle, there is ovulation. After ovulation, okay, that endometrium will develop secretory phase. And at the end of that secretory phase, there is stoppage of the progesterone secretion because of the degeneration of corpus luteum, and that will bring menstruation. So this is a periodic structural change of endometrium of the uterus. It occurs due to rhythmic change in the rate of secretion of female hormone, especially estrogen and progesterone. And the duration is 28 days plus 7 days. Sometimes it may occur in 35 days, sometimes even longer than that, sometimes even lesser than 28 days. So there are different abnormalities of the menstrual cycle. In the subsequent classes, we'll talk everything regarding them, everything. But this is a normal one which we are talking about. Normally, exactly 28 to 30 days. That is the normal one. Now, there are three phases of the menstrual cycle: proliferative phase, secretory phase, and the menstrual phase. Let's talk about them. Now, before we go into each of these description, okay, let's quickly highlight this slide. See here, this is the menstrual phase where menstruation occur from 0 to 4-day menstrual phase. Period occur or menstruation occur during this time. Then up to 14-day, okay, this is a proliferative phase. The shedded, okay, endometrium will again slowly, proliferates here. And ovulation occurs exactly during this time. After ovulation, there is formation of the corpus luteum. There is release of progesterone. Progesterone will lead to formation of secretory endometrium. So this is known as secretory phase. And during this time, again, progesterone will rapidly decrease, which leads to menstruation. So this is an ongoing process, one after other. And this will only occur in reproductive, age, and that is 15 to 45 years. Some lady may develop this even, beyond 45 years. It depends. So these are the phases of the endometrium: menstrual phase, proliferative phase, and secretory phase. The secretory phase is a fixed one, okay, and this proliferative phase is a variable one. Now, why it is written like this? Let me clarify. Sometimes the cycle is not 28 days. Sometimes it may be 32 days or 33 days. But remember one thing: ovulation occurs exactly 14 days prior to the first day of menstruation. Exactly 14 days. So if there is a 32-day cycle, that means ovulation occur on the 18th day. 18th day, exactly 14th day prior to that. So that means the proliferative phase is variable, isn't it? It may be longer than the usual one, but secretory phase is usually fixed. So this slide, okay, is shown here just to revise ourselves once again. FSH is more during the follicular phase, okay. This is known as LH surge, okay, and then it leads to the ovulation, and then a luteal phase will start, okay. Luteal phase will start, and after that these hormones will come back to the normal one. Now this is the synthesis of estrogen, and this is the synthesis of progesterone. Progesterone level is very high in the luteal phase, and estrogen level, it is more high in the proliferative phase, but even in the luteal phase it is there. It is constantly secreted. Now this is about the proliferative phase. After period or menstruation, the basal layer, which is known as the deeper layer or portion of the uterine gland and the blood vessel, it remains. So remember, these are the parts of the endometrium. These are the different layer, isn't it? Something known as basal layer. So it remains there. From there, everything will come back again. I can compare this with the skin layer or epidermal layer. There are different layers, and the downmost or the lowermost is called stratum basal or germinativum. If that remains, then everything will come back again from that layer. The same type of concept here. Under the influence of estrogen, regrowth of the endometrium occurs, and regrowth of the spiral arteries also occur. It begins during the later stages of the menstrual flow and continues through the 13th or 14th day, okay, till ovulation occur. During that time, proliferative phase will continue. Let me remind again, it may be variable. If the cycle is quite regular, okay, we know exactly what is the length of the proliferative phase. Otherwise, it is a variable one, whereas the secretory phase is a constant one. Now, let's talk about secretory phase. See there? In secretory phase, there is hypertrophy of the endometrium. So the cells will even become bigger there. Okay, they become taller also. At the same time, there is increased vascularity and increase in edema. Okay, they become swollen also. All these are important type of development for the upcoming implantation, upcoming implantation. Always think like that, because the situation should be favorable. If the lady becomes pregnant, the fertilized ovum should be implanted there, and all these environment is for that purpose. The spiral artery and the glands become coiled here. The endometrium acquires three layers, okay, during this time, like basal layer, spongy layer, and compact layer. These are a bit of histological description, but the most important point you already know. Proliferative phase is maintained by progesterone and make endometrium ready for the implantation, and it lasts for 12 to 14 days. Okay, usually it lasts for 14 days. This is a constant type of period. Now the same thing is shown here once again, so that you should never forget it. And this is the period of menstruation. This is a menstrual flow, proliferative phase, and secretory phase. See there, progesterone is a dominant hormone during secretory phase, and it will make that endometrium stable. Estrogen is a dominant, in the proliferative phase, and that type of endometrium is unstable, means it can shed very easily. That's why in case of an ovulatory cycle, where there is no ovulation, there is no progesterone, on and off bleeding is very common during that time. Okay, even in the mid cycle, the bleeding can happen. This is known as metrorrhagia. So we'll talk all about that during the disorders of menstruation. Now, why menstruation occur? What is the exact mechanism which is going there? See this? With decrease in progesterone, the spiral arterioles will constrict. The spiral arterioles which are present in the endometrium, they will constrict. Now, at the same time, there is release of prostaglandins, especially PGF2 alpha. PGF2 alpha. Now, because of all the these substances, there will be further narrowing of the spiral arterioles. Okay, spiral arterioles, which leads to necrosis and sloughing of the endometrium. Along with the ova, which is not fertilized, the endometrium will slough off, okay, and it will come out as a menstrual flow. So this is known as period or menstruation. Now, same thing is written here now. It occurs for 3 to 5 days and characterized by blood flow. This is known as menstruation. It occurs when ovum fails to fertilize and blood, progesterone, and estrogen level fall due to degeneration of corpus luteum. Never forget this golden statement. If a lady is pregnant, menstruation doesn't occur. Okay, menstruation doesn't occur. That is known as amenorrhea. Okay, it is a type of secondary amenorrhea. Pregnancy is the most important cause of secondary amenorrhea. But if she is not pregnant, then the ovum fails to fertilize, isn't it? We all know that. Then corpus luteum will also disintegrate. It will degenerate. Then menstruation occurs. Approximately 2 days before the menses, the quantity of estrogen and progesterone sharply decrease, which cause involution of the endometrium due to decreased hormonal stimulation. And this is what happens: sharp fall in estrogen and progesterone, constriction of the spiral artery, the mechanism we have already discussed. There will be anoxia or hypoxia and ischemia of functional layer of the endometrium, which results in necrosis and sloughing of the endometrium, leads to bleeding. Okay, the functional layer of the endometrium has these different layers: spongy layer, basal layer, and those things. So they will slough off, resulting in bleeding. This is known as menstruation. Now, to summarize everything in a slide form, see here, from hypothalamus, GnRH is released. GnRH will act anterior pituitary, and FSH and LH will be released. FSH will act on ovarian follicle. Okay, it will lead to growth of the ovarian follicle, and estrogen is released from here, isn't it? But during that time, because we are talking about the late luteal phase, the corpus luteum will be degenerated. It will be degenerated, right? So there will be no synthesis of progesterone. So without synthesis of progesterone, there is spasm of the spiral arteries. At the same time, prostaglandins also play a very active role, resulting in menstrual flow. So this is the a basic concept. Now, what is the composition of this menstrual blood? Okay, what type of substances are there? See here, around 30 to 70 ml blood. This is the normal thing we are talking about, or during the normal menstrual flow. Functional layer of the endometrium, some of the tissues are there, mucus, unfertilized ovum, and even fibrinolysine. Okay, fibrinolysine. Because of this, the menstrual blood doesn't clot. It doesn't clot. But actually speaking, if there is a heavy type of flow, then she will pass clots. Now, this is the normal thing which we are talking here. Okay, means the menstrual flow is not heavy or massive, but in heavy flow, which is known as menorrhagia, there would be present a blood clot. Or let me talk in another way. If blood clots are present in the menstrual flow, that means the menstruation is heavy. Okay, and this is how we ask the question to the lady. Now, how it is controlled? Okay, again a bit of summary for you. Okay, now see this. This is the formation of the different type of steroid hormone from the ovary. In follicular phase, estrogen is released. In luteal phase, progesterone is released. Now, see that. So this is the basic thing which we have already discussed. Okay, see here. FSH, okay, and LH. This is known as LH surge. Estradiol comes in the proliferative phase. Progesterone comes in the luteal phase. These are the different phases of the development of follicle. Ultimately, graphene follicle will form, leads to ovulation, corpus luteum development, and corpus albicans form. And these are the changes which occur in the endometrium. See this: hypothalamus, pituitary, okay, then gonad, and ultimately endometrium. So this is known as hypothalamo pituitary ovarian axis. Hypothalamo pituitary ovarian axis, and this is most important regulator or controller of the menstrual cycle.